We'll start with the obvious, with EGFR mutant lung cancer, which has sort of been the leading edge of targeted therapies for advanced stage non-small cell lung cancer. Zoshi, you want to walk us through where we were, where we are with current therapies for EGFR mutant lung cancer, and from that we'll use that as a launching pad to discuss some of the data from today and some of the abstracts.
Yeah, so it's 2019. EGFR mutations were first discovered in 2004, so 15 years. And I think, it's really remarkable how much progress we've made, but also remarkable how much more progress we need to make for these patients. Right now we actually, in the US, have 5 different EGFR inhibitors that are approved for first-line use in EGFR. So the first generation EGFR inhibitors are erlotinib and gefitinib. Second generation EGFR inhibitors, afatinib and decomitinib, and then of course osimertinib, the third generation EGFR inhibitor. And really since 2004, we've had a long list of first randomized studies comparing the first gen TKIs and the second gen TKIs to chemotherapy, clearly showing the superiority of the targeted therapy for a patient with EGFR. Then I think, as we got more and more of these drugs, we started to see some comparator studies where we actually started to see, first comparisons of second generation EGFR inhibitors to the first. So the LUX-Lung-7 study compared afatinib to the first generation TKIs and really didn't show much of a benefit. I think it's important in kind of this historical perspective and in where we are to point out the Archer 1050 study, which was a first-line study that compared decomitinib, another second generation TKI, to the first gen drugs. And that study was actually positive. So we did see an improvement in PFS as well as actually an improvement in OS with decomitinib. I think the caveats to widespread adoption of the Archer 1050 regimen were that decomitinib as a second gen TKI had quite a bit of toxicity, the typical EGFR toxicities, diarrhea and rash, and about 2/3 of the patients in that study had to dose reduce decomitinib. And the other key caveat is that the Archer 1050 study excluded patients with brain metastases, which is a big population here. So, right around the time that the Archer 1050 data came out, we also had the Flora Trial, which I think is the one that of all the recent EGFR studies has been the most practice changing. And Flora was a large randomized phase 3 study that compared osimertinib, the third generation EGFR inhibitor, which had first actually been developed for the second line, for patients who progressed on a first or second generation TKI and developed T790M, the resistance mutation that we see in about half the patients who progress on a first or second gen TKI. And we had previously seen that osimertinib not only was very effective for T790M positive disease in that setting, but also was very well tolerated and very CNS penetrant. So lots of kind of favorable features about osimertinib. In Flora, we compared osimertinib to erlotinib or gefitinib for newly diagnosed patients. Flora did include patients with brain metastases at baseline, and we saw, I think, a very nice result with PFS as the primary endpoint and a near doubling of PFS to about 19 months with osimertinib, which was really a nice result. Now, we haven't yet seen overall survival data from Flora. The early interim analyses have looked promising, but important to know that data are still immature, and we hope to see it. But I think in addition, again, we saw that OC was very well tolerated, really low rates of any significant diarrhea or rash, very low rates of dose reduction. And we saw really good results in the CNS. We saw that patients benefited whether or not they had brain metastases at baseline. And we also saw lower rates of progression in the CNS in patients who were treated with osimertinib. So I think for all of those reasons, I think that osimertinib really has become the standard of care for newly diagnosed EGFR patients. And really the question then becomes, where do we go from here? Yeah. How do we improve upon it?
So nice summary. Is there a patient which one of you would not consider osimertinib for an EGFR positive patient? Is there a circumstance where osimertinib is off the table?
You have to work really hard.
You really do.
Yeah.
I mean, technically, because it has some anti-HER2 activity. In theory, there's some cardiac failure reported very rarely. I guess if somebody was a cardiac cripple, you might think twice. The trouble is they've also got a lethal disease in their cancer, and I think you'd still probably do it.
Yeah. So that's the one, I've been asked this question a lot. That's the one scenario where I, one time in my clinic, had a patient who had very severe cardiac disease and was elderly, and we were worried that any risk. With OC though, the rates of cardiomyopathy are very low.
Like
just a few percent. Yeah, 2%. Yeah. QTc prolongation again occurs, but it's low. And I think it's important to know that for most patients who have cardiac disease, it's important to monitor. Periodic EKGs, echo. but it's not
For
an
patients with
absolute-
cardiac
for,
disease.
exactly,
Okay.
for patients who are at increased risk of cardiac toxicities, but it's not a contraindication really unless you really have that extreme case where you really are.
I think technically the label says you're
Yes.
supposed to do routine
Yeah,
echoes.
who's
echo
doing
not.
that?
I'm like
No.
voting hands down.
For patients, I would say for patients who have, for example, a pre-existing history of CHF or something like that, yes, but routinely, no.
Well, if they're on it, they suddenly become short of
Yes.
breath. Like, okay,
Well, there's a lot of things then you have to look at, right?
Correct.